In this lecture, we will focus on scene management and triage.
Namaste. Today, we'll be talking about scene management and triage. Scene management is about having a clear and organized plan of action at the scene, which is very helpful in situations that are complex and involve multiple casualties. Triage is assigning each patient at the scene a priority by which they will receive medical treatment. The process of triage is important because we want to attend to the greatest number of people. Spending a lot of time and resources on one patient may prevent other patients from receiving medical care. Let's start to talk about it in more detail.
Triage is especially important in mass casualties incidents, or MCIs. MCIs require considerable resources and personnel and requires a clear management plan. It is very helpful to set up an incident control system, or ICS. The ICS is comprised of 4 components: command, scene size up, communications, and organization. Command is a person responsible for managing the scene. Each person who is managing the scene is able to control 6 people, or 6 first responders. If the situation is more complex, then command can assign sector officers for more help. Scene size up is very important. This is where we make a quick sweep of the scene to gather information such as safety and hazards, number of patients, priority of care for each patient, which is triage, the need for extrication, the number of ambulances needed for transportation, the areas where we may set up resources, or other factors affecting the scene. Communication is also very important. Scene size-up information must be communicated to other respondents and communication centers so that everyone can be on the same page. An incident command system may also include an EMS command, which consists of a triage officer, a treatment officer, and a transportation officer. Multiple casualty incidents, or mass casualty incidents, are already very chaotic. Organization is key to avoid uncoordinated activity at the scene, and it also helps to set collective priorities. Triage is the act of assessing and assigning patients priority. This helps to attend to the greatest number of people because spending too much time or resources on any one patient could compromise the health of the rest of the patients who are awaiting your care. Here, we have provided a diagram to help quickly classify each patient according to priority. If the patient can get up and walk, then we assign them priority green. If not, then we'll want to assess the respirations. Are they breathing? If the answer is no, then we'll look at the airway. If they have an open airway, then they will be assigned priority red. If they do not have an open airway, we would give them the priority of black. If they are breathing, but not 10 to 30 breaths per minute, they will get a priority of red. If they are breathing 10 to 30 breaths per minute, we will then look at their perfusion or circulation. As you may notice, we are going through the ABCs. In terms of perfusion or circulation, if they have a normal radial pulse or cap refill less than 2 seconds, then we will want to consider their mentation. If they do not, then they will be placed in the priority of red. If the mentation of someone with normal circulation is poor, then we will look at them as a priority of red. If they have normal mentation, then they must have minor injuries, and we will put them into the category of yellow. Here we show the priority based on colors and numbers, red being 1, yellow being 2, green being 3, and black being 4. Patients with priority 1 have treatable but life-threatening illness or injuries, and they must be treated first. This would include patients with breathing difficulties, uncontrolled severe hemorrhage, decreased mental status, shock, or severe burns. Priority 2 patients have serious but not life-threatening conditions. They must be treated after priority 1 patients. This would include patients with burns without airway problems, who have major or multiple bone or joint injuries, or back injuries. Priority 3 patients are termed walking wounded. They must be treated after priority 2 and are described as having minor injuries. Priority 4 are the dead or fatally injured patients. These patients will not receive treatment unless no other patients are at risk of dying or suffering long-term disability. These patients would be patients who have exposed brain matter due to a major head injury, no pulse for over 20 minutes, or have been decapitated. Now, we ask that you pause this recording so that the trainees may complete this triage exercise. The answers are on the following slide. Patient 1 would be assigned red. Patient 2 also would be assigned red priority. Patient 3 would be assigned yellow priority. Patient 4 assigned black, and patient 5 assigned green priority. The secondary triage allows us to separate patients according to priority tags. Each treatment sector should have its own treatment officer. The treatment officer will re-triage patients within a particular sect. This is a triage that occurs after the initial triage to look for life-threatening injuries. This allows us to further assess the status of our patients. Staging and logistics are also very important to determine in which order patients will be transported to the hospital. As you could imagine, there are always a limited number of vehicles to transport patients to the hospital, and in some cases, a limited number of beds in the hospital for them to be placed. The staging officer keeps track of ambulance vehicles and EMT personnel, whereas the transportation officer approves ambulance transport and keeps track of hospitals that each patients are sent to.
I hope you found this presentation helpful and gained an understanding of scene management and triage. Thank you for listening to our talk. Dhanyavad.